Hello, everyone. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us again for our weekly briefing on preventing and managing COVID-19 in the workplace. This is our 15th week of webinars, and unfortunately, there's a need to continue them. And in fact, we've seen the case rates rising, which I'm sure Dr. Harris will address during today's session. He'll also be talking about contact tracing, which is an interesting subject from many perspectives, so I'm looking forward to hearing more about that. As always, this session is being recorded, and the recording will be available on the WorkCare TV YouTube channel by the end of the week, and we also will be posting our questions and answers from this week's session on our website. We follow the same procedure every single week, so you can see every Q&A from the past 14 weeks. And during the webinar, we'll be posting the links to those two resources. During the session, please use the Q&A function on Zoom, and we'll address as many of the questions as we can in the time that we have allowed for the webinar, which is 40 minutes. Dr. Harris typically speaks for about half an hour, and then we have about 10 minutes left for questions. So let me introduce Dr. Harris for those of you who don't know him. Anthony Harris, MD, MBA, MPH, is a board-certified occupational medicine physician. He's WorkCare's Chief Innovation Officer and Associate Medical Director for On-Site Clinical Operations. He's also our lead clinician for our COVID-19 response. And today, Dr. Harris is joining us from California. He's normally based in Chicago, but he's out on the West Coast doing some work with us, so he's in my time zone, which is nice for a change. So now I'll turn it over to him. Thanks very much for joining us.
Excellent. Thank you, Karen, and thanks to everyone for joining us once again. And indeed, I bring you greetings from California, from LA, and we're out here helping the media industry get back up and running with COVID testing. So it's been a pleasure to be out here and looking forward to talking today about contact tracing and how it plays a role in our COVID surveillance program. And we'll obviously do some updates here that you're familiar with regard to the clinical update, the pathology or microbiology of COVID-19. We'll brief on the epidemiology as it stands today in the US and a little abroad. And then we'll go into the preventative strategy and workforce strategy for contact tracing in particular for this particular session. So without further ado, let's get into it. So clinical presentation, one of the things we've heard recently, just in the media in general, has been, is there a shift to more young people being affected by COVID-19? And not just affected, but are they presenting clinically with more significant disease than they have previously earlier in the pandemic back in March and April? And so what I wanted to present today was just briefly looking at what does the data look like in regards to the distribution of cases of COVID-19 as it pertains to the US in particular. So the number of individuals in this particular data set from the CDC was 1.9, almost 2 million individuals. And we can see the distribution age-wise of the cases. And obviously, the highest rate of cases is occurring between that 18 to 44 years of age. This is the cases, but not necessarily the severity. And when we look at the severity in regards to who doesn't perform well, who may have unfortunately bad outcomes from COVID-19, those numbers are still consistent of what we've seen in the past, in that those individuals 65 and over, particularly those 75 and over, having poor outcomes, obviously having pre-existing conditions, also contributes to those poor outcomes. And those numbers are consistent over time. But what we also want to look at in this particular chart is looking at the mortality. And is the mortality shifting to a higher or younger population, as it would. And so what we can see, again, this data coming from the CDC, we can see the death counts attributed to COVID-19 based on and grouped in the particular age ranges. And in that red, the highest death rate in that red tracing there, you can see 85 and over at the top. 75 to 85, 84 years of age, secondarily, and then it proceeds down to the bottom of the chart here, 0 to 24 years of age. So we haven't seen the shift in particular of a age group, particularly in the younger group that we're looking at and questioning in the media, right? Succumbing to COVID-19 with regard to death. So we can look at this data further in future webinars to understand, are we seeing just a higher proportionality of symptomatic younger people than we were in the past? So far, there haven't been any studies that I'm aware of that look particularly at that metric, but hopefully in the weeks to come, we can see some additional published data so that we can identify, is the virus mutating to an extent that it causes more disease presentation symptomatically in the younger population. So for the pathologic update, we're going to talk about what's happening in the US with regard to deaths from coronavirus. And we're going to identify some hotspots in regards to particular states, right? Because we want to know, is the mortality rate increasing? Is it rising? Is it something that we need to be concerned about moving forward in regards to the spikes that we've seen in the US in particular, right? So when we look at the US and the death rate, we're seeing those increases broken down by COVID-19 specific diagnosis and then other diagnoses such as influenza and pneumonia. And if we look particularly at the number of deaths that's expected, and we kind of touched on this with other charts and other data that we presented several weeks ago, but we're looking particularly now at the number of expected deaths or percent of expected deaths in the US that we would have normally during this period of time. And is that higher, is that percentage higher as a result of or correlating to COVID-19 diagnosis? And so that percentage that we want to identify is the 103 number you see in this chart, meaning that 3% higher, greater than the number of deaths that we would see normally during this period can be attributed to COVID-19. And we can see the additional numbers here, specifically looking at diagnoses. In the column identifying deaths involving COVID-19 and pneumonia and excluding influenza is 46,208, all right? And if we look at the total of deaths involving pneumonia, influenza, or COVID-19, that number is 182,625, and that's the number on the far right. And so let's identify, let's go a little deeper. Let's now stratify this list of all the states and some cities based on percent of expected deaths at this point in time. Are we over what we expect, or are we at what we expect, or maybe even under what we would expect, which obviously the 100 mark is the baseline, right? That we, when we cross, can anticipate the deaths attributed from COVID being greater than what we would normally see. So let's look at New York City. New York City is experiencing 112% greater percentage of deaths than we would at this point in time otherwise, right? If we look at another hotspot, Massachusetts, they're 23% greater. If we look at Illinois, Chicago area is driving this 12% above that 100% mark. So in fact, we are having disease and death attributed mainly from COVID-19, greater than what we would normally see, and again, based upon CDC data. So we want to keep that in mind. We'll keep watching those numbers and those statistics to see how we're faring in the U.S. in regards to our not just response from a social distancing effect, but also from a healthcare impact effect. Let's get into the numbers that we typically cover for epidemiology across the U.S. and a little beyond. If we look at where we were 2 weeks ago, we were at 1.9 million cases. Last week, we went to 1.1 million cases. And then this week, as of today, we are at 2.3, as of yesterday, excuse me, we're at 2.3 million cases in the U.S. Number of deaths obviously have increased as well. Now we're cresting 120,000 deaths in the U.S. If we look then at daily new confirmed cases in the U.S. versus other countries, looking at this particular curve, again, 7-day rolling average, you all should be familiar with this metric at this point, but we're watching it, and we've watched it now for some time. This is what it looked like in terms of the curve flattening 2 weeks ago, what it looked like 1 week ago, and now what it looks like as of today. We're seeing for the first time that increase in slope, not decrease, okay? So we wanna make sure, again, looking at confirmed new cases, we were downsloping and flattening and downsloping quite nicely for weeks past. Again, last week where we were, maybe seeing a slight increase, and then where we are today, a definitive increase in newly confirmed cases on a 7-day average. All right, so make no mistake about it, we're seeing the spike that we anticipated, right? We've been saying for months now, we anticipate a spike once social distancing was relaxed. We saw it, Wuhan, China saw it, Singapore, another country saw it after they relaxed their social distancing. We are seeing it now. And the question is not just, all right, are we seeing it, but now to quantify and watch the trend over time, because we're looking for it to perform similar to our neighbors across the pond, in that the numbers hopefully will come down again. But time will tell, obviously, as we anticipate these numbers. Let's look at confirmed deaths. The slope here decreasing 2 weeks ago, continuing to decrease last week. And as of today, we're seeing it flatten, not decrease. And we'll watch it for next week to see if we have a spike or an increased slope from those confirmed deaths. We looked at this number or this particular metric and this particular map last week. For the first time, we identified that the range in which we were in the US in regards to our share of positive tests, meaning we go out, we sample the public, and what percentage of those samples with regard to COVID testing come back positive, right? The range we were in as of June 1st was 2 to 5%. And we saw this metric change when we looked back several weeks from being in the range of 5 to 10%, going down to 2.5%, and then going back up to that 5 to 10%. And we know that the number of tests have been improving in the population, which should, if the incidence of disease is decreasing, should lower the number of positives per percentage of tests, right? But what we saw again is that we went from that 2 to 5% increased to 5 to 10% last week. And if we look at it again this week, the scale reported by the CDC has changed a bit, but we're still in that 5 to 10% range, as we can identify in the data as of yesterday. Okay, so we'll continue to watch this metric and identify, are we doing better or are we doing worse? If we continue to jump into the next level of percentages, that means that we may be having increased incidence of COVID, not just attributable to increased tests. Okay, and that's an important metric that we want to pay attention to. So now let's talk about prevention. Let's talk about contact tracing. Let's talk about its relevance. Let's define it first, right? So contact tracing being a methodology for identifying individuals who have been in close contact with a COVID positive confirmed, laboratory confirmed case or individual, or a presumptively positive COVID individual. And close contact is better defined now, as we talked about 1 or 2 sessions ago here, better defined now by CDC as having a temporal relationship. If you recall, we've been defining it temporally in regards to 10 minutes for months, right? And that data coming from Wuhan, China, and what other countries have identified as a risk factor for COVID close contact. So CDC now defines 6 feet, within 6 feet of an individual for 15 minutes or greater as the definition of close contact, which we translate into a true exposure and increasing risk for having transmission of COVID-19. Now, that is presuming there's no proper PPE being worn in that encounter, right? Let's keep that in mind as well. But contact tracing is a methodology for hopefully quickly identifying those individuals that may be at risk because they've had that defined close contact with a COVID positive, laboratory confirmed, or presumptive positive individual. And the steps to quarantine them and take those measures will CDC has laid those out a little clearly than they have in the past at this point, which is great. We've been talking about those processes of how to manage those cases in the past. So we won't spend much time on that, but we do want to get deeper into contact tracing, defining it, and making sure that we have a methodology and understand the methodologies for deploying contact tracing in various ways, okay? So let's look at the kind of, bare guts of the workflow for contact tracing, right? It starts with traditionally a patient interview or a worker interview, right? And so in this case, we're talking about the individual who is positive for COVID-19. And and what's recommended is that interview occurs remotely, meaning don't bring them into the site, don't bring them into your office, call them, telephonically have an interview with them so that you're not increasing risk for transmission as a result of just that personal encounter, face-to-face encounter. But an individual then undergoes an interview during which identified individuals that they've had that defined close contact with is delineated, and then those contacts are then triaged, right? So we want to qualify those contacts to that definition, right? If it wasn't within 6 feet for longer than 15 minutes, that's not indicative of increased risk of transmission of COVID-19. Right. We know that various employers may be a little more conservative in their approach to that definition, and hopefully they're not less restrictive than that definition. Right. But when we talk about the next steps, that contact then is assigned into a triage cohort. They're notified and appropriately tested or not, right? If there's testing available, then the process can include that testing methodology. If it's not available, then referring them to appropriate services to have a presumptive diagnosis and care. And then it flows into the medical support, right? Referring the individuals as necessary, plus or minus their positive results from testing. And then we want to make sure, obviously, the steps are in place in the process for the quarantine, the self-quarantine. So what methodologies, when we talk about capturing that initial piece of this workflow, can we deploy to help employers scale their operations with regard to doing this contact tracing, right? So the first, straightforward methodology, if we can break the methodologies into 3 categories, the first one is just the historian interview, right? This is the classic approach using EHS personnel, using safety personnel, or HR to walk through the process for a positive individual and identifying those who may be at risk in the workplace so that we can deal with them appropriately with quarantine or not. The next category we're calling asynchronous automation for that piece of the contact tracing process. And then the final category being synchronous automation. So what do these mean? How are we referring to these and how do we characterize the workflows here? So the classic approach, again, uses a human interview we call it human interview, uses EHS and HR personnel, and they speak telephonically with an individual. That's what we just finished talking about, right? But in that interview, what data should we be capturing? This is an example of real data de-identified in this case. So when you do the contact tracing, obviously you're going to capture the name and the phone number, contact information, and obviously we de-identified it in this case, but we also want to capture then the relationship to the person in question. So the source patient is first. You capture the data on the source patient, the interview date, the last date that they may have had their exposure that caused their positive confirmed case or presumptive. And then you're going to walk through the location of exposure, the average exposure time, right? Duration, because that's a key factor, looking for that 15-minute threshold. The frequency is also important, right? So if you're within 6 feet for 5 minutes, then another 5 minutes, then another 5 minutes, guess what? That adds up to 15, right? So each encounter should be cumulative in exposure. That's nothing new when we talk about occupational health and exposure in the workplace. We know that dosimetry or dosage is a factor in transmission of COVID-19. So you have to capture the exposure frequency in these particular processes for contact tracing. And then you want to describe the exposure. How did it happen? Was there PPE involved or not? Et cetera, right? Personal contact and whatnot. And then any recent symptoms. So symptomology is important in regards to particularly those presumptive cases where there's no testing available, right? And the clinical algorithm, we can talk about it another time, but again, we want to capture that information. And then any pertinent notes, right? In terms of trying to understand how the contact happened and hopefully preventing it from happening to other workers in the future, capturing that there. And then you're going to walk through all the coworkers that may have had exposure and walk them through the same questions, right? You want to capture the frequency, the time of exposure, duration of exposure, et cetera, et cetera. And so as you do that, you're also going to capture many times, and again, this is kind of the cusp of what you're able to do from an HR EHS standpoint versus what we're able to do as clinicians, but you can go into a little household family member exposure history so that you can understand who may be at risk, because that may play a role in whether or not you go above and beyond with regard to getting an individual tested to help protect themselves as well as their family. So that is quickly an overview of the information that is pertinent to capture for contact tracing using the human interview approach. So what are the advantages? Obviously, we're able to capture the context and the history in the same transaction, in the same interview, right? We're able to also secondarily have the opportunity to educate, triage and educate that individual. So if they need to see a healthcare worker, we can let them know that during that encounter. If they have an opportunity to learn about the best practice for preventing COVID transmission in the household as they quarantine, that's an opportunity that we can take advantage of during that interview. And then finally, capturing the contacts in all different settings for the workforce is key as well, right? So let's say they're in the office, or let's say they're in the workplace at the facility, and then they go off site somewhere and they're still having encounters with other coworkers. We're able to capture that complexity simplistically through that interview. Right, and we'll talk about in contrast that approach and that advantage over some of the other two categories here. Disadvantages, something called recall bias introduces uncertainty around capturing everyone who may be at risk, right? An individual may not remember that they had contact with so-and-so for 15 minutes within 6 feet 2 days prior. Right, and that's an important metric to capture as well. We want to go back, and these are the clinical recommendations from CDC and beyond, that an individual should have 2 days prior captured the contacts, and that's 2 days prior to either them being confirmed positive from laboratory testing, or from them becoming symptomatic, or from them having a close contact with a confirmed case, laboratory confirmed case in that regard. Okay, and then another disadvantage is it's hard to scale this, right? We know that there may not be enough HR, EHS professionals available if you have large scale operations to manage the contact tracing, and particularly if incidence is increasing and these contact tracings become more frequently necessitated, excuse me. And then delays in contact notification. Because this takes time, it's time intensive, there may be a 24-hour, 48-hour, or even greater turnaround between contacting or getting the list confirmed of who the contacts are potentially, and then reaching out to those individuals as well. So that's a quick and dirty overview of advantages and disadvantages of the human interview approach. So now let's talk about the asynchronous automation approach, okay? The asynchronous automation approach is geospatial data collection of workers. In this case, you can do every worker potentially in a defined region. That region is generally referred to as geofencing, okay? And that's demarcated in that red zone there in this theoretical workplace campus, all right? And then what is enabled in this case is that positive cases can be correlated with a historic record of proximity. So you can capture data, store that data, and if an individual becomes positive, you can refer back to this data to see whether or not that positive individual had a duration and proximity to warrant a potential positive exposure. Okay, and in that scenario, obviously, then you have a expansive list that you can quickly reach out to and do the contact tracing methodology that we talked about during the human interview. Okay, and asking those particular questions. So it takes that first piece of the contact tracing approach where you're trying to identify who may have had contact, and you're automating that piece of it so that it's a more comprehensive and more complete list. And that is the benefit, one of the greatest benefits of this approach. Now, how do you do that? Oftentimes, the solution may be an app, right? We've seen Apple and Google some time ago talk about coming out with their contact tracing app. There are limitations, obviously, that have prevented them from launching those apps and having adoption of those apps. And there are also methodologies to utilize existing cell phone service geospatial data capture. If you have, let's say, Wi-Fi set up at your facility, you may be able to utilize that Wi-Fi network. Let's say you use Cisco to capture the cell phone movement of individuals without any additional app download, right? And it would just be an agreement that each individual with a mobile device in that geofence zone would have to agree to. And once you have that agreement, you're able then to use that data that's already being tracked to notify an individual of a potentially positive encounter with a positive case. Okay. Obviously, there are some advantages and disadvantages. Advantage: it captures that data geospatially, and it does so in a historic record longitudinally. Right. So once you begin it, you have that on record, and you can always refer back to it at any given time. It automates the historical record more complete, again, more comprehensive in regards to understanding who may be at risk. And then you can leverage existing worker hardware with this approach. If you have a mobile device, you may be able to use that without having to have additional deployment of resources or hardware in order to pull this type of automation off. Obviously, the disadvantages may be the cost of the service and IT integration, right? So if you're using an app, or even if you're using the geospatial data that's already provided through the Wi-Fi service that you may have, you still need to integrate that data somehow into an existing EHS or HR process. And that may have additional costs. And then the employee and union may push back, right? We've seen this play out already in things that we've been involved with, where the union says we're concerned about privacy and we want to make sure this is an approach that's feasible for our workforce, right? For our union. And that can stop the operation from moving forward, implementation from moving forward. The workforce may not have, in the last disadvantage here, they may not have available mobile devices, right? We know that there are certain populations that don't have access to a mobile device. And that mobile device, even if they have it, may not be able to be utilized because of intrinsic safety concerns in the workplace, right? And so those are limitations from a hardware standpoint for this type of asynchronous approach. Again, asynchronous referring to capturing data historically, storing that data, and utilizing it in the future, cross-reference with a positive case. So what does synchronous automation look like? So synchronous automation typically utilizes some type of wearable device, right? And it captures, just as the asynchronous, that geospatial location of workers, but it does so also in a real-time setting, right? And so not only can you have that historic record to back reference, you can also have the advantage potentially of a real-time notification for doing social distancing in the workplace, right? And so that advantage comes with oftentimes an additional device that needs to be worn by every worker. But again, in that deployment, there are some clear advantages. Primary prevention now is something that's at your fingertips because you're generating leading indicators for risk with that real-time spatial data, right? So you can track, are people at work practicing safe social distancing, because again, you're tracking it and giving those real-time notifications. And if you see those numbers, that leading indicator, start to trend downward, meaning that people are not utilizing social distancing as strongly as they were, let's say 2 weeks ago, you can offer an intervention, right? Coaching or education, and you can hopefully prevent that threshold from being crossed of within 6 feet for 15 minutes. So that data now becomes available with this type of deployment. And then the other advantage is there's no opportunity for capturing additional personal identifiable information, right? It's not using a personal device. We're not capturing personal data other than associating that geospatial data with, let's say, an employee ID. Okay, and that may remove the anxiety from a data safety, personal identifiable concern with the union or with otherwise employees at large. And then there's no pre-existing hardware limitations, right? So there's no concern that, hey, you don't have access to a cell phone or a mobile device because you're providing the hardware to each employee. And we see clear advantages of that approach when we're talking about distributing this type of system and implementing it. And then the disadvantage is obviously additional costs of the hardware and the service provider as well. There are scalability issues in terms of man hours. This is referring to a previous slide. I apologize for that typo, but the disadvantage here that I wanted to address specifically was the disadvantage of not having the availability of the hardware to be used in the particular setting, right? And that speaks to the third piece here. Let's say there is no Wi-Fi setup, you'd have to set that up de novo, right? Some cases you need to set up a mesh network with certain devices, and that becomes an issue. The second piece was around the intrinsic safety of the device itself. That may be a clear disadvantage depending on your work site and the safety concerns thereof. So those are, again, a quick overview of advantages, disadvantages of those three categorical approaches to contact tracing. But one thing remains clear: no matter which category you choose, there's still going to be necessary steps that will be either done by your EHS and safety or outsourced, right? And in particular, that interview still has to happen, right? You still have to qualify the individual's status in regards to their presumptive or positive status, right? And then notifying those other individuals with a phone call, telehealth phone call, most likely still needs to occur, right? And that's going to take time and effort. And then when we talk about the support from a clinical standpoint, obviously that's another ball of wax, so to speak, that needs to be tackled, again, either insourced or outsourced. And so I'm going to be unabashed in saying, that's where you want to partner with your clinical provider. In this case, WorkCare does perform these services so that it becomes straightforward in regards to the role HR and EHS process has to play, where there are boundaries between those boundaries between what you may ask from a historical standpoint and how you manage clinically moving forward. The burden is not on the employer and the EHS and HR staff. So with that, I hope this has been an insightful overview for you. Obviously, we can go in more detail with questions if there are some regarding these type of approaches, but we wanted to get your mind thinking about how best to utilize these type of technologies and approaches to help with contact tracing, particularly now that we're seeing increases in numbers of cases, and we know that we're going to be dealing with this throughout the summer and potentially the fall even worse. This is going to become paramount to your organization in terms of keeping workers safe and doing primary prevention. Thank you so much, and we'll take some questions.
Thanks, Dr. Harris. This is Karen again. A couple questions about contact tracing, and then there's a number of questions about testing, but we may not have time to get to all of them. So say you're in a workplace and someone is suddenly obviously absent, and the word gets around, well, so-and-so's absent, and then these coworkers start getting calls from a contact tracer. What can you do to ensure the privacy of the person who's the carrier? It seems like, I mean, I know the contact tracer doesn't reveal the identity, but it seems like it'd be really hard in some circumstances to protect that person's privacy. Do you have any recommendations?
Sure. I mean, so in terms of the classic approach, it's hard to do, right? An individual is positive and you want to confirm with their potential contacts that they may have had or to confirm that they did indeed have close contact with said individual that is positive or presumptively positive, right? You can leave that information out, right? You can choose to do that in your process, and certainly you just need to be more articulate about the encounter itself, right? One of your coworkers in the break room on such and such day around 2 p.m. Was positive for COVID-19, presumptively or laboratory confirmed, and then go directly into the other questions that help identify what is that individual experiencing. Are they symptomatic? Have they had any additional contacts outside of work or inside of work otherwise, et cetera, right? So you don't necessarily have to identify the source patient by name. If you can articulate where the exposure occurred and the temporal relationship adequately to inform the person that you're speaking with regard to potential contact. Now, the benefit of the technology is you can de-identify that entire process, and it gives you more objective data around the encounter, right? You don't have that recall bias that you have to cross the barrier of with regard to understanding and confirming the nature of the encounter.
Okay, regarding synchronous automation, can you share any insights or success stories regarding the use of wearable contact tracing devices enabled with Bluetooth technology within the work environment?
Sure, I can't speak to any specific numbers in terms of benefit and impact, but we know that certain scenarios have been publicized. For example, Ford implemented contact tracing with wearable watches about a month or so ago, and they reported they saw a benefit, right, in terms of decreasing the number of potential COVID cases. So we know that these type of technologies, one of our other partners that we have at WorkCare is currently implementing 2 different types of automated approaches, and we'll be able to participate in that data more closely and share that data with you hopefully in the near future. But again, we know that companies are adopting these technologies and there are reported benefits. It's just going to be long-term what is going to be the percentage impact over what can be done through the manual process. In theory, it should be, for large organizations, very advantageous to use automation.
What about work sites that don't allow employees to use cell phones on site, which seems to be becoming more prevalent?
Absolutely.
Then they have to go back to the manual method of interviews, in-person interviews.
Yeah, so I mean, that is obviously a circumstance. We've seen in that scenario the third party hardware be beneficial, right? Because there are no opportunities for workers to become distracted by other functions of the device itself as they would with their cell phone. And those devices themselves can be produced intrinsically safe as well. And we know those devices are available so that you overcome those limitations in terms of having hardware that's compliant and able to be deployed on site.
Okay, another question about contact tracing. Are you suggesting contacting the primary person daily or also contacting all the people that person was in contact with on a daily basis?
Neither. So this contact tracing is not a daily contact process. It's only a post-exposure type of approach, meaning that particularly with asynchronous, the data is historically captured. And if an individual should become positive at any given time, then you're able to look back within the appropriate time period and see who may have had close contact, defined again, within 6 feet for 15 minutes with that person. And then that's who you reach out to with the interview appropriately. Same thing would happen with the, obviously the synchronous and asynchronous. The benefit being that the real-time notification hopefully is going to prevent that threshold from being crossed because social distancing hopefully will be better maintained in that scenario. So no daily notifications, no daily calls. This is only daily capturing the geospatial information that's used later to identify who may be at risk.
Okay. Unfortunately, we only have time for one last question, so I encourage all of you to check the website for the Q&A or the invitation we send out every week for the webinar. We also post the links on that invitation, which we typically send out on Monday. The final question, how long after potential contact with a COVID positive or presumptive individual should someone get confirmatory testing or diagnostic testing?
Sure. So if testing is available, it's recommended to do so at any given time during the course of their post-exposure period, right? And in particular, obviously, that's within that 14-day period in which somebody's going to be either developing symptoms or having potential risk for transmitting COVID if they did in fact become infected with it from another workplace encounter. So testing, if you can do it, it's recommended in a post-exposure contact tracing algorithm. If it's not available, obviously, then you can still adequately triage and deal with that exposure and have that individual self-quarantine for the prerequisite period of time. And if later the availability of testing, particularly with the antibody testing, is more widely available, then it's reasonable to go ahead and have that individual tested to see if they contracted and developed immunity to COVID-19. But again, the recommendation is clear. When available, testing should be performed after a exposure, so post-exposure process. Uh-oh, did we lose you, Karen? All right, well, I think I'm still on and hopefully everyone can still hear me. I think we may have lost Karen. So what we'll do is thank everybody for joining us, and do stay tuned for the questions that we didn't get to be answered and posted as Karen has articulated here previously. And stay tuned once again for our webinar coming up next week, same time, same place. And hopefully some more additional interesting content here for you. So on behalf of Karen, on behalf of all of us here at WorkCare, again, thanks for joining us, and we'll see you next week. God bless, take care, and be safe.